Hello, my name is David James Smith, MD. I'm the Medical Director of San Diego Comprehensive Pain Management Center and Pacific Surgical Institute, a fully licensed and accredited ambulatory surgical center here in Metro San Diego. We also have locations in El Centro, California and Chula Vista. I'm double board certified in physical medicine and rehabilitation and pain medicine with an emphasis on interventional pain medicine. I've been in practice now over 28 years, and we provide outpatient interventions to treat chronic pain. Some of the advances in the last 8 to 10 years have revolutionized the treatment of chronic pain and spinal disorders. Previously, many of these disorders had to be treated with hospitalizations and required months of rehabilitation. Current advances allow us now to treat these same conditions with outpatient procedures. This allows you to return to function quickly and to get out of pain faster. I hope you enjoyed this digital video library that we have created that shows some of the more exciting advances in interventional pain medicine. Look for us on YouTube at San Diego Pain Center. Once again, I hope you enjoy these videos, and please feel free to contact us and check us out on social media as well. Thank you. This procedure is called a intrathecal pump trial, and we are going to mark an area on the low back. I don't know if you can see that image there to the left. Lots of hardware in this patient's back, and we use these for failed back syndrome and chronic neuropathic pain. Pump trials are done to determine if the patient is a good candidate for a permanent pump implant. And the pump that we use is a Medtronic SynchroMed 2, a 20 or 40 milliliter pump. I'm anesthetizing the skin with lidocaine 1%, getting it nice and deep so the patient doesn't feel anything. We can use sedation with this, and if patients are nervous, we do. As with all of our procedures, conscious sedation is provided. There's a lot of hardware in there in the form of isola rods. Now I'm just going to introduce a needle into what we call the subarachnoid space, and you can see liquid coming out. That confirms that I'm in the central nervous system space. The catheter is then brought to the field and very gently introduced into the hollow needle and advanced to approximately the T8, T9 level. And it's usually done without complication, usually 98% of the time, and it's painless. If the needle is angled correctly and with a gentle forward push, as you can see, I'm not aggressively pushing the catheter and stylet in. I'm going very gently, 1 to 2 centimeters at a time, where my assistant is feeding me the catheter. And the idea is to put this in where all the nerve receptors are in the central nervous system. Fluoroscopy confirms that the catheter is going in the right direction and that we are heading up north or towards the neck. I continue to advance the catheter until I'm at about the T8, T9, or T9, T10 level. Once the catheter is in and the needle and stylet is removed, we will do what's called a thoracolumbar myelogram to confirm its placement, flush it with preservative-free normal saline, and then secure it to the skin. This catheter will then be attached to a transition port or connector, which you see right there, and then it will be hooked to a digital CAD pump that will deliver a certain amount of medication per day. We usually use fentanyl and Marcaine as our medications because I've done this now for 26, 27 years, and those medications produce the best effect with the least amount or no side effects for the patient. So I'm a big believer in those two medications for the trial. I've confirmed that I'm in the right spot. I'm going to use some Omnipaque, which you see right here, to produce my myelogram. And Omnipaque is very viscous, so that takes a long time to go through the catheter. And we'll get a picture of the myelogram, which you can barely see on the screen, but trust me, that's the myelogram. Because it's so sticky, we want to clear that now with preservative-free normal saline. So you see me pushing the Omnipaque out and the saline through. And as that Omnipaque goes out, you can see the plunger increase its rate of descent because the Omnipaque is no longer there. So the patient is completely painless during this. I put the cap on, and then we go ahead and attach the catheter. As mentioned, that's a transition port to the bag once it's secured to the skin with Tegaderm and a dressing. The pump trial starts at 0.2 mils per, a rate of 0.2 mils per hour, I believe, and is kept in for approximately 7 days. IV antibiotics are given for the trial, and PO antibiotics are given during the 7 days. We encourage patients to come in every other day for rate adjustments. We also make them make a pain diary so we can see how much we've decreased their pain and we decrease their oral opioids, or they completely stop their oral opioids when this is being used. This is the transition port being hooked up to the CAD pump that already has a medication prepared. This will be again secured with some more dressing. The nice thing about a intrathecal pump trial done this way is it's much superior to determining successful outcomes for pump implant than a single shot is. A single shot done in a hospital is really artificial, in my opinion, and doesn't do anything to determine whether or not you're going to have a successful pump implant. However, by letting the patient resume their life, having them keep a diary, becoming functionally active, decreasing their opioids over 5 to 7 days, if not completely stopping the opioids, you now have a real-time diary as to the efficacy and effectiveness of a pump trial in real time. So for those of you who think that a single shot is the right way to go, I respectfully disagree with you. I think it is absolutely not the right way to go, and that if you really want to get a good idea as to whether or not your patients will respond to a permanent pump implant, a catheter subarachnoid intrathecal infusing for 7 days is the way to go. And there it is, voila. There's the catheter in the subarachnoid space, clearly going up